Everyone, we'll start with our session. Ladies and gentlemen, innovators and healthcare enthusiasts, a very warm morning and welcome back to the second day of the InnoHEALTH conference. We hope your minds are buzzing with the inspiration from yesterday's insightful discussions and networking opportunities. Today promises even more exciting sessions with cutting-edge innovations and collaborative solutions shaping the future of the healthcare. Without further ado, I invite Dr. Kamini Walia, Senior Scientist at Division of Epidemiology and Communicable Diseases, Indian Council of Medical Research, New Delhi. During her 20 years of experience in public health space, she has initiated and successfully steered numerous projects and programs in space of healthcare. She is currently leading the Antimicrobial Resistance Initiative of ICMR, which focuses at various aspects of AMR, including surveillance, antimicrobial stewardship, and OneHEALTH aspects. We welcome you, ma'am, and I request you to please address the mass.
Thank you. So good morning, everyone. It's a cold Delhi morning, and I read in the newspaper today that the temperature further dipped, and we are now colder than Shimla. But then, thanks to all of you who turned up this morning. So I will be broadly talking about the challenges of antimicrobial resistance, what has been the global perspective on this, and what India is doing, and why it is so difficult to contain antimicrobial resistance. So as most of you would know, the first antibiotic was penicillin, discovered by Sir Alexander Fleming, and which also earned him the Nobel Prize. So following this first discovery of the first antibiotic, we had almost a golden era of antibiotic development. For 50 years almost, we had very many products which were developed. They were from different classes, the fluoroquinolones, the aminoglycosides, the combinations, and many other products. And that was actually called the golden age of antibiotics. Unfortunately, it did not last very long. And the development of drug resistance actually followed development of every antibiotic or antimicrobial like a shadow until 2010, when UN declared antimicrobial resistance a public health threat. And following that, we have been facing different challenges related to antimicrobial resistance, which I will be talking about. I would just like to mention here that in last few years, we have not seen development of any significant antibiotic or antimicrobial. The reason I say significant is that they were mostly analogs or products of modified the same antimicrobial. And what it has led to is that now antimicrobial resistance is recognized as the public health threat. It is one of the top 10 public health threats recognized by WHO. One of the disease burden estimates, which was published in 2021, and that is the pre-COVID data, it said that antimicrobial resistance claimed almost 4.95 million lives in globally, and out of which more than 1 million deaths were directly attributable to antimicrobial resistance. In India, what we see is that development of antimicrobial resistance in a patient actually incurs 40% more cost for the treatment as compared to the drug-sensitive infection by the same pathogen. COVID-19, we saw that excessive use of augmentin, azithromycin, and many other antimicrobials, so it actually led to deprioritization of whatever efforts were going on antimicrobial resistance containment. And what we see now is that there is a large burden of hospital-acquired infections in our country. Most of the patients who are admitted in the hospital acquired infections from the hospitals. They are mostly caused by multi-drug resistant pathogens, and they are also very difficult to treat. So we have this huge burden of HAIs. They are invisible threats which claim invisible lives. The reason I call them invisible is that there is no government system which is actually monitoring that how many lives in the country are being lost because of antimicrobial resistance in health-acquired infections. And this leads to higher medical costs, prolonged hospital stays, increased mortality. And one of the worst outcome of this is further selection of the resistant strains, because then these patients are further treated with a lot of more antimicrobials. So antimicrobial resistance is a multidimensional problem. What we all understand is a clinical or the medical dimension of this problem, what we see in the hospitals. But underlying this problem are our inequities, whether it is a social inequity or economic inequity. And also, it is driven hugely by the economic, regulatory, and the policy issues. And we will see how. So antimicrobial resistance develops in response to antimicrobial pressure. And what actually leads to development of antimicrobial pressure? And that is something as simple as antimicrobial use. And you are bound to use an antimicrobial, but what we do not understand is that whenever the diagnosis of a disease is compromised, which most of the times happen in our country, whenever there is a poor infection control, and whenever there is no knowledge or understanding of the fact that irresponsible antimicrobial use leads to antimicrobial resistance development, we will be unknowingly created antimicrobial pressure. Added to that are some of the factors like over-the-counter antibiotic sale in our country, excessive use of antimicrobials in veterinary sector. And one of the most important factor, I think, is the poor perception of the problem. Most people do not understand that the pills you pop, something like a norfloxacin when you have a diarrhea, which may be a viral diarrhea, or the irresponsible use of antimicrobials, for example, for a upper respiratory tract infection, which may be viral in cause. All those things lead to development of antimicrobial pressure and put the whole community at the threat of antimicrobial resistance. At somewhere, you can actually relate it to the climate change, the climate-related issues. For the climate-related problems, the carbon footprint today, what kind of impact it has in future, nobody understands, and the perception of the risk is poor. Similarly, for antimicrobial use today, what kind of threat it will have in future, we do not understand. 70% of the antibiotics are actually used by the livestock, the agriculture, and the poultry sector, and only 30% are used in the humans. And even in the ones which are used in the animals through or the agriculture or the livestock, through different mechanisms, is actually lands up in our water bodies, it lands up in our system, which again puts threat on the humans. Also, we have this climate crisis which is now building up. More people are displaced because of the climate crisis, because of the floods, because of the droughts, than war or any other things, although things may change post what we are seeing in Israel and Palestine today. But when millions of people are displaced, they do not have access to clean water, they do not have access to good medical care, and all these situations actually precipitate infections, and which result in further development of drug-resistant pathogens and increasing transmission and their spread. So in India, we have antimicrobial resistance surveillance network, which is being funded by ICMR for last 10 years. And these are the 3 groups of pathogens which we have prioritized for aggressive actions, for sustained action, and for monitoring. Overall, gram-negative organisms cause large number of infections in our country. Almost 70 to 80% of the infections are caused by gram-negative infections, and E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter cause large proportion of infections, and they becoming resistant to drugs like carbapenems make them a very important threat for treatment. And also typhoid and fungal infections, they all classify for continuous monitoring, which ICMR continues to do. We also look at different mechanisms of resistance and how they are changing over a period of time. What we see is that we have a lot of OXAs and NDMs, which are the genes which cause resistance in these pathogens. And most other countries have a very different gene profile. So that's why the needs of the Indian patients will be very different. For example, there are many new products which will be introduced in the market in the near future. And what we understand is that many of these products may not be able to help Indian patients because they will not be effective against the pathogens and the drug resistance mechanisms that are prevailing in India. So this is the sad part, and that is why we need more indigenous efforts. And all this is perpetuated because of the fact that there is a lot of broad spectrum antimicrobial use in our country. Most of the times, in absence of a definitive diagnosis, doctors prefer to use broad-spectrum antimicrobials, whether it is BL-BLI combinations, whether it is carbapenems. I see even for very simple infections, doctors prescribing linezolid when you can treat it with something very basic and a narrow-spectrum antimicrobials. So all these factors actually precipitate this problem. Now, this is a very interesting flowchart which shows the reservoirs of antimicrobial agents and antimicrobial resistance genes in different areas like soil, lakes, rivers. What we see is that antimicrobial agents, which are depicted by the straight lines, and antimicrobial resistance genes, which are depicted by the circular lines, they all land up into the humans through different channels. So that's why if we really want to address antimicrobial resistance, we need a multi-pronged approach. But the focus initially, priority should be humans, but because what we saw from some of the studies that we funded in India, we found that the nature of antibiotics which are used in animals are very different from the ones that are used in humans. So if we are seeing very high resistance to carbapenems or piperacillin tazobactam, these antibiotics are used only in humans. The animals use fluoroquinolones, aminoglycosides, but when we took samples from the hospital and the environment and the poultry, there was a good overlap between the human and the environment, but we did not find the same drug resistance genes in the poultry. So if we really want to address the increasing levels of resistance in humans, we need to focus on the human side and have interventions in the clinical side. Another study which was carried out in more than 80 countries actually found, they looked at the urban sewage. What they found was that the airplane travel, which we many a times think would be transferring pathogens across continents or countries, did not contribute much to those transfers. But it is the World Bank indicators like sanitation, the hygiene, clean water availability, they lead to precipitation of antimicrobial resistance in different countries. So if for AMR containment, we need to improve our understanding of the transmission of AMR, what are the drivers, what is the impact. We need to advocate for prioritization of AMR mitigation and inform policy makers, and also strengthen the evidence base for the interventions. And that is what ICMR's research has been focusing at. This is the National Action Plan for our country, which was launched in 2017. Unfortunately, the plan was to address the awareness and understanding, improve the knowledge through evidence generation, improve the infection control in community as well as the hospital settings, optimize antimicrobial use through different interventions, support research and development, and also have a good leadership at the country level. Unfortunately, not much could be achieved in the first phase. because as you now understand that it is a multidimensional problem. You need to bring in environment ministry, the water and the sanitation, the human health, and so we really need a good mechanism which can bring all these multidisciplinary teams together and also motivate them to invest in this particular problem, the research related to the problem, and move forward. So COVID actually, I think, taught us a lot of public health lessons, and this is a review article I wrote with my team on what are the lessons that we learned during the COVID that we can actually use for AMR containment and improving the stewardship and the framework. So there were few learnings from the COVID. First is that we really focused on the diagnostics. Every lab was strengthened, and the COVID diagnosis actually was the mainstay of the COVID program. The other was that we did a lot of digital data collection and monitoring using the dashboards. So that is something that AMR can benefit from if all the labs which are doing, if they can be connected through the digital platforms, and that data is monitored very closely by the government. So that is something that we, and that is where you all can play an important role. And the most important was the governance and the leadership here. Since it was being monitored at the highest level, at the level of the Prime Minister, at the Home Minister being involved. So all that led to funding being channelized in a proper place, proper monitoring which happened. Then the vaccines play a big role in that COVID program, and also the risk communication was done very effectively. I mean, if you look at AMR, we haven't had a single national level campaign for antimicrobial resistance, and how public and hospitals and all the stakeholders can actually contribute to containment of this problem. But national efforts are crucial, and that is something we have to keep moving forward for. And the reason is that we are 18% of the world population. So if we really want to address AMR, we have a very peculiar health system as well. We also have a unique pathogens, which I just mentioned. So we need the solutions which actually address our local problems and give us solutions that are sustainable, that are affordable for our populations. So moving forward, we would need more inter-sectoral collaborations, harmonized protocols for One Health surveillance. We need better stewardship practices around antimicrobial use in humans, animals, how we can use vaccines for better antimicrobial stewardship. And all this is going to come from research and innovation, whether it is a clinical research, the basic research, or the implementation and the operational research. And if we don't do this, India will miss out meeting many sustainable development goals, which in any case we are falling behind because of COVID and other issues. These are the different guidance and documents and resources which are available at ICMR website, which anyone can access. Thank you. This is all. Yeah.
Thank you so much, ma'am. Our session converges on the nexus of One Health and climate change. Today, we embark on the journey to explore the profound interplay between human and environment health in the face of a changing climate. The dialogue ahead promises insights into the challenges, solutions, and collaborative strategies essential for a healthier, more resilient future. Without further ado, let's invite our panelist, Dr. Tavpritesh Sethi, Associate Professor, IIIT Delhi. We welcome you, sir. Dr. Selva Murthy, President, Amity Science, Technology and Innovation Foundation, Director General, Amity Directorate of Science and Innovation, Chancellor, Amity University, Chhattisgarh, and Chair Professor for Life Sciences. Dr. Selva Murthy has served the Defense Research and Development Organization, Ministry of Defense, Government of India for 40 years. We welcome you, sir. Next, we have Dr. Shendu Mukherjee, Mission Director, PMU, DBT Bairak, DMGF, Wellcome Trust. Sir is a trained medical microbiologist having global and national exposure with more than 2 decades of high-level work experience in top organizations, which helps to bring to fore cumulative perspectives on issues related to healthcare. We welcome you, sir. Next, we have Dr. Manjunath Shankar, Senior Public Health Specialist. He has over 14 years of work experience in international public health and has evolved in the CDC's EOC response to West Africa Ebola outbreak. He has worked as an advisor, consultant, health economist, and infectious disease modular for different entities in various capacities. We welcome you, sir, and let the session begin.
Thank you. So, first of all, thank you all who have joined us on a Saturday morning. Thank you, Dr. Kamini, for the wonderful keynote address and for laying out what the challenges are in the AMR space in front of us. So I'll start this panel. We are starting about 10 minutes late. Actually, we started 5 minutes late, so we'll stay on time. We'll take 5 minutes extra for the panel discussion with the permission of the organizers and Sachin. So to briefly introduce the challenge, which then I will request my esteemed panelists to comment upon from their own areas of expertise, I will just have a brief outlay of what we see as the interplay and interconnectedness of One Health and climate change. I'll start with a brief presentation around that area. Can you have my presentation? It's my presentation.
So you can access this from here?
Sure. Perfect. So I'll just come here and talk, right? So I think it's much easier to. So I think the challenges in One Health and climate change have come into recent perspective. And why do we need One Health approaches, right? So Dr. Kamini in her slides showed one of those slides where the reservoirs of AMR can be in soil. Most recent example being air pollution being carrier of AMR, a paper that was published in the Lancet, because air particles can actually, the bacteria can get deposited on PM10, and this effectively can actually lead to spread of AMR as well. So why do we need One Health approaches, right? I'll just briefly introduce our own journey through this experience in the last 10 years or so. It started way back in 2013. Basically, we were integrating diverse heterogeneous data sets. And this was before I had a lab at IIIT Delhi, where we had data from all across India and data from OPDs, more than 3,000 OPDs on patient symptoms, right? And initial analysis are all statistical analysis, but then the key point, which led to some interesting insights, but the key point was this particular AI model here, where these 200,000 patients' data were overlaid with indicators from districts in which these patients were seeing the doctors from. And then when we lay these indicators on top of these OPD data sets and put AI models on top of these, we actually saw something interesting emerge. In a completely unbiased manner, we saw that the LPG consumption in districts of India was directly related in a causal manner to the emergence, to the occurrence of obstructive airway disease and asthma. So this was one of the first examples where we basically were able to model that if we were to increase LPG penetrance across India, the obstructive airway disease would actually fall by half. Fast forward to 2022, where we were working with this large AMR data set on more than 6 lakh isolates from 17 different countries collected by the Wellcome Trust and made openly available from year 2004 to 2017. And we had this longitudinal data And essentially, again, we applied a similar approach, which Dr. Kamini alluded to, that there are world governance indicators, World Bank indicators, which can be indicative about the levels of antimicrobial resistance in that particular region, right? And in a data-driven manner, this is published in the Journal of Global Antimicrobial Research, we were able to actually show that world governance indicators and antibiotics, you may not see a line here, but they are actually having a causal relationship. Similarly, antibiotics are related with world governance indicators. They are digging deeper, we find that the access to maternal and child health care has an impact on AMR. But where does this access give the maximum bang for the buck? A counterfactual analysis showed that the middle income countries, for example in ceftriaxone, would benefit the most if we were to take action on these indicators. And this would be lesser in high-income countries. Now, this is all because these data were available and the indicators were available. In collaboration with ICMR, Dr. Kamini, with support from Dr. Kamini, Dr. Harpreet Singh, who was yesterday, we have further carried out such analysis for within India data sets. Apologize for, I think some of these fonts are not visible because of, I think, the screen brightness. But in this study across 20 different sites, we are able to show for the first time, not just the rates and trends of AMR as they are increasing, but also their linkages with sustainable development goals of the states. So 20 different sites across India, alarming trends for resistance patterns like imipenem resistance. But these are tightly interlinked to, for example, the achievement of Sustainable Development Goal 3. And this is data that is taken from Niti Aayog. What I'm trying to say here is that we already have lots of data sets residing in heterogeneous, siloed locations, right? There is a need to bring together these data sets, and that's actually what sets up the next challenges. And this is actually proven for both UTIs and sepsis. This is the again, a similar trend observed in imipenem resistance and SDG3 in bloodstream infections, that is sepsis, right? So both of these papers are under revision. In another work, which I'm not going to go deeply into, we are actually showing how climate change is impacting emergency services across India, especially in the state of Gujarat. This is work carried out in collaboration with Stanford, where we basically are facing a lot of challenges in integrating different data sources. Although we are finding some indicative patterns that there is a link between temperature surges and emergency use. But there's a lot of challenges, for example, data go missing, data not linkable, and so on. So that brings me to the key challenges and questions that I would be posing to the panel. Not only from the perspective of work that I have presented, but to open up, and please keep these at the back of your minds as well to ask questions at the end, where we'll have about 10 minutes, that we need to raise awareness that health needs to be viewed from the One Health perspective. Animal health, environmental health is not different from clinical observations. How do we make that happen? We are busy probably chasing short-term goals. It's changed right now, I believe, with a lot of effort being put into One Health and AMR and climate change. But we have a long way to go. There's a lack of systems thinking. We need to really start thinking with data in terms of systems and not individual isolated data points. There's lack of data. And when we talk about climate change, we are talking about decades. So where do we have these decades long of data, and how can we make this possible and happen? Or how can we actually bring together existing data sources to actually create such? Relatively immature data science approaches. Being a data scientist, I can actually say, even in our works, we know our assumptions, we know the challenges. We are not there yet to integrate these various different scales of data sources together. So we need better data science approaches. Government funding is catching up. We see a lot of support initiative from national as well as international agencies, but where are the private funding models? Because AMR, One Health, other approaches, essentially we would need more private financing. Although it is a problem which is not like cancer, we will not see immediate impact, but it is for the health of the planet. and it is for our sustainability and, generations, not just 2 generations, maybe 10 generations ahead. We need to start thinking about that. So with these questions and challenges, I will request my panelists to shed light upon their own thoughts and their work in this direction. So I'll just join back on the dais, and I'll start with Dr. Selvamurthy. Sir, you have been a part of many policy documents, and I'm bringing a policy up front from the standpoint of the long-term vision and where we need to go. So would really be very keen to know your comments and insights on some of these challenges and maybe more. Yeah.
Can I have the presentations? Friends, good morning. First of all, let me compliment the organizers for choosing this very important theme, looking ahead, maybe generations. I see youngsters here. So you are all concerned about how does the climate change, which is a reality now, how it is going to affect not just only human health, the health in totality, that is the animal health, the environmental health, and even the microbiological health. So everything together is One Health. So I'm going to take you through some of the efforts, the policy requirement, technology requirement, which we need to address in terms of the climate change. My association with this topic started way ahead in 1983 when I was invited to World Meteorological Organization as 12 experts chosen globally to formulate the policies for climate and health. There was a separate section on WMO, World Meteorological Organization. So in 1983, we started this from India. I represented India there. So that time we were looking at how does a tropical country like ours, what are the challenges we would encounter with regard to climate change. So not that climate change we were worrying about just now, but we have been thinking about it for years and maybe decades. So my appreciation to the organizers. So when you look at this, climate change and its impact on health, there's a number of, if you look at the incidents happening in the just last couple of months, 4 months if you take, there are almost about 560 or so many incidences happening. The number of medium, large-scale disaster incidents happening is almost about 560 per year. By 2030, it is going to be of that. Heat alone, the global warming which is happening, which is putting the heat burden, which is the death is almost about 5 lakhs, which is attributable to only the increase in temperature. And similarly, there is 55% increase in heat-related disorders and also deaths, which is happening now. So it is happening, and so it is a reality. Now, how do we address this? It has to be an integrated, as Dr. Walia mentioned, that you need to have a multi-dimensional and also multidisciplinary and policy, technology, practices, behavioral change. Everything is required to address this problem. So it cannot be just only by technologies or by policies. So we need to look at how do we prevent this happening. What is happening today? How do we prevent, mitigate, slow down the occurrences? How do you predict and detect the attributes of climate change-related health disorders? And then how do we respond? And these are the ways in which we are addressing it in our country. And we should mobilize multiple sectors, disciplines, communities, so to address this. So that should be a challenge. And how do we do that? I will throw some thoughts on that. So this is a climate change, the flow chart. If you have to look at, you need to consider the extreme weather events which is happening now, floods, earthquakes, and also the cloud bursts. So many weather extremes, the extreme weather events which is happening. heat stress, air and water quality, which is being affected, which you are seeing today in terms of air pollution, water pollution, and the food security and safety is another challenge which will come because of the climate change, and also the vector distribution and ecology. That is also going to cause infectious diseases in particular. Then when you look at this flow, then you need to look at two important sectors, the vulnerability factors and also how do the health systems resilience will be challenged. In the vulnerability, demography, if it's a dense population like ours, which is 1.4 billion people in a small area, then the infectious diseases and the spread contagiousness, vulnerability is much more. So the demographic profile and also the aging population growing up, that will be yet another challenge because of the vulnerability. Then geographic, if you are close to equator, you have different challenge. If you are close to the poles, you have different challenge. So another factor, vulnerability factor, will be geographic location of your country. The third one is biological. All the bio reserves which we have, bio assets we have, and the biological wealth we have. So that will also be another vulnerable factors. And we have the richest biological wealth today in the world. Human, 1.4 billion people, 50% below the age of 25 years, and also equal number of animals, and also the biodiversity and GDP of agriculture sector contributing to 15%. So all these are vulnerability. Socio-economic and political. And this is again, because once the migration take place from rural to urban, and also the socio-economic conditions will be challenged, and also the political system. So this is how the vulnerability factors, and when you look at the health system and capacity, resilience, and leadership and governance was mentioned, and also the workforce information system, products and technologies, which I will be touching up. Ultimately, this is going to increase this health risk. When you look at the injury and mortality, if it is earthquake, flood, cloudburst, so you can have injuries, heat-related illness, respiratory illnesses due to pollutions, waterborne diseases, zoonotic diseases, which is going to increase in a big way, vector-borne diseases, and also malnutrition and other related, including mental health. This is a very complex slide which I am showing now. So there are two things which you need to look at. Climate driver will be changing temperatures, changing precipitation, and changing weather patterns. So these are the three major climate drivers. Then if you look at the pathways, the air and air temperature going up, I'll take one quadrant here. If you just look at only the increase in the air temperature, elevated the air temperatures and longer growing season, and then ultimately it will lead to prolonged exposure to heat, increased ground level ozone, which in turn will affect the health outcome will be the heat-related illness, cardiovascular disease, asthma, allergy, respiratory illness. So you see one side the exposure pathways and also health outcomes, how much the climate change can influence. I have just enlisted in this complex slide, but then everything is interconnected. So if there is a drought, it's going to increase the dust, increase the pollens, vector-borne infections. So everything is interconnected. So it's a very complex process. Then if you look at the vector-borne diseases, these are some health impact challenges. Vector-borne diseases will be on the increase. Food and waterborne disease, respiratory disease, cardiovascular disease, allergy, mental health, and food security challenge. And these are the ways in which you can address, and the challenge will be on forestry, agriculture, fisheries, and all those will be interconnected in terms of food security. I will just narrate one incident which happened in Ladakh, which is in high altitude in the western Himalayas at 4,000 meters. And can you think of a locust in such a climatic condition, sub-zero temperatures? But this has happened recently, locust in Ladakh. And then that in turn, the nymph, the eggs, they produce nymph eat away all the pasture lands. So the Pashmina ground, the grazing grounds, is now completely finished. So then this swamps and then moves to another location. So the complete thing was lost. So this is happening because of the climate change, the warming of the temperature in Ladakh, cloud burst happening. So all this is related to the locust appearance in Ladakh. I'm just giving one example. Similarly, if you have to build the resistance, you need to take care of 5 factors. The first is forecasting the climate impacts and assessing vulnerability. You need to be able to forecast. This is where the AI application, data science, and also all the information which we have through the data sets, which we need to use it for forecasting the climate change. The next should be the projecting the disease burden. Because of this, what will be the projected disease burden in different dimensions, be it waterborne disease, airborne disease like pollutions related to respiratory illness. So you should be able to project the disease burden. Then the third component will be assessing full public health interventions required to handle that disease burden. So that will be the third step. And the fourth step should be developing and implementing climate and health adaptation plan. How do we adapt climate resilient cropping and climate resilient the health provision in terms of public health? And so you need to have all this, the adaptation plan. Because humans, Homo sapiens, have a great resilience to adapt. Be it a high altitude, you are deploying a soldier at 22,000 feet altitude, which is a physiological limit of the whole system. So that resilience, adaptability of the Homo sapiens have to be used. Similarly, evaluating the impact of improving quality of activities, we need to look at how, once we give intervention, what is the impact? Have we really intervened and then also produced, ameliorated the problem? So you need to assess the impact. So this is how we need to approach this problem. And so India, we are the pharmacy of the whole world. Today, during the COVID, which is an infectious disease and highly contagious, and today we have been able to give the vaccine within a few months. So this is what is the inherent strength available today in the country to lead the world in terms of giving the right intervention, even climate-related challenges. Similarly, we have the biotechnological strength, Bharat Biotech, Shanta Biotech, Biocon, so many industries. So I'm just giving the inherent strength to combat climate-related diseases. Then there are emerging technologies in which the country is already working. There's like multivalent vaccines, because the diseases may not be a specific individual disorder. So you need to have multivalent vaccines, edible vaccines, and also multiple sensor arrays for disease diagnosis, multiplexing instead of looking at each pathogen separately. So we need to have the pharmacovigilance. Mobile health kiosk will be coming in a big way, because once you are in a disaster situation, the health care will go to your location. So we'll have mobile health kiosk and mobile health care delivery system. Then personalized medicine, telemedicine, and e-health. And I see the digital health mission taking up in a big way. And so these are the things, the gene editing, pharmacogenomics, early biomarkers, biosimilars, in which our country is already working. So these are the ones which will come to intervene and then meet the challenges of the climate-related health disorders. I'll just quickly go through. The novel therapeutic intervention, targeted drug delivery, stem cell research, gene editing, and also health technologies. We need a lot of focus on that. Health technologies like ventilators, we will need large number. Organ transplant, this is going to be a big challenge, which I will say it will also be related to health disorders, because your liver will be spoiled. When I look at the lung today, there is no pink lung available today because of the pollution. So these are all changes, climate change, which we are, in some way it's connected with that. So you will have to replace your organs periodically. So you will need this type of artificial organ implants, which will come in a big way. Yeah, just I'll conclude. I'll go to the last slide. So we will need AI platform to speed up all the, whether it's repurposing of drugs or it is vaccine development, we need to look at AI platforms. Integrating the allopathic and modern system of medicine. Agriculture, climate resilient cropping, which I can bring out during the discussion. I put all this precision agriculture, protected cultivation, and finally the policy. The chair just triggered the discussion on policy. The scientific social responsibility is one such policy which is required, that we need to connect with the society and see the changes which is happening due to the climate change. And so this is climate resilient policies. The final message is you need a comprehensive approach to climate resilience. It cannot be just only ICMR alone or only the DBT. We have to work together, everything together. So there must be a comprehensive approach and address the intricate relationship between global warming and climate change and human health in an integrated way. So I would now bring it more in the discussions, and thank you so much.
Thank you, Professor Sellamurthy, for these insightful. So we'll take the questions at the end to all the panelists in common and also for the keynote. Next, I would like to request Dr. Kamini Walia as a program implementer, as a funder, researcher. So what challenges and opportunities do you see in the space of One Health and climate change? And you've alluded to many in your presentation, but any unique perspectives and insights for the younger researcher generation that you would like to? Data being one of these, I think many of the students here would be very much interested in data, but would love your insights there.
Thank you. Very important question, because there's a lot of focus on One Health now, and at the global level it has gone from tripartite to quadripartite for especially AMR. There are 4 agencies now at the UN level which are actually responsible for AMR containment, and which also includes the animal and the agriculture and the environment component. First one is, of course, evidence generation. We continue to generate evidence and identify the points for where, the funds which we have today to address all these big challenges are best utilized. What will be our return for investment? What will be those point of interventions? I would just like to add here a word of caution that, many a times we take coincidence as causality. And that is something that we have to refrain from doing. That many a times the findings are coincidental sometimes, and identifying causality to it is very important. For example, there was a paper which was published a few years back which said the NDMs increase in the Ganges during the tourist season. During the summer vacations, a lot of families visit Haridwar and Rishikesh area. But what is the public health impact of the rising NDMs in Ganges, and how does it actually impact the clinical dimension or the human dimension which we face the problem with, or with the transmission? All that needs to be worked out, and that's why we really need good understanding of how to design those studies which answer those research questions. And just saying that, okay, we see a lot of NDMs in Ganges is nothing. Has no public health relevance. So that's one thing that I want to emphasize. Similarly, the study that Dr. Sethi pointed out, I had a low level of conviction for the study that the air pollution increases drug resistance. I would say it increases upper respiratory tract infections, and then it increases antimicrobial use, which actually leads to more drug resistance. That is something that is more plausible than saying that only drug-resistant pathogens stick to those pollutants and we inhale that. So that's something that there has to be a word of caution there, because ultimately relevance of what we do is very, very important. And of course, I think we should try to create more data management systems and also capture the relevant data, the demographic data, the economic data, because these are the data points, as I said, the underlying reason is inequity. So that's something that we have to bring out, so that, now there are so many schemes through which we are taking care of nutrition. One of the TB studies, the most important study which came out recently from India, was that if you give food supplement or ration to the TB patients, the therapy has a better impact. So those are some of the studies which we really need. And of course, climate change, no one knows how it is going to evolve, and we have to be prepared for that.
Thank you, Dr. Walia. Thank you especially for bringing up the point on data and possible confounding in many of these analysis and studies. I think we all have hypotheses, data being the proof of the pudding is basically needing it. So I think the data evidence needs to be generated in a manner where all these data sets can be integrated. I think ICMR has a very strong role to play there, and would request all the policymakers here to really bring together initiatives to make these data sets available and also linkable, so that such questions can be answered with proof from data, not only as hypothesis. I now go to Dr. Sheshendu Mukherjee, again, leading the BIREX programs, many programs, and supporting many such activities in the space of biomedical research and grant challenges that you're supporting. You have played a very crucial and important role in bringing resources to a lot of data-based studies. So a lot of data science evidence has been generated through your initiatives at BIREC and Grant Challenges India. What is your thought on climate change, which is even a bigger challenge? From my perspective, and AMR and OneHEALTH, would love to hear your insights on how do you see India's vision going forward.
Thank you, Tavpritesh, and thank you, InnoHEALTH, Sachin and his team for the invite today. And esteemed my senior panelists, I think Dr. Selvamurthy, Kamini, and Dr. Manjunath. So I come from an organization called BIRAC, which is a Biotechnology Industry Research Assistance Council. It is an agency of the Government of India through the Department of Biotechnology, which funds innovation. Not only funds innovation, but enables innovation. That is a critical part of our day-to-day job. We not only fund, but we enable innovation, and I'll tell you how enable, and then I'll connect to what Tavpritesh gave me released his question paper to me, but he slightly tweaked the question paper. So I had a presentation for that, but I'm not going to give any more. So, okay. So I am a storyteller. So because I always tell, I do a lot of grant writing workshops, and in grant writing workshops, I tell winning a grant is how compelling story you tell. And story is a unique thing by how to win. It should be, let's say, like a fairy tale. It should start with once upon a time. All fairy tales start like that and ends with happily lived ever after. So that is the concept of winning a grant is. So coming back to what I was talking about is, so we enable innovations. We fund, of course, 60% our job is to fund and 40% is enable. Now, enabling innovation, and I lead a platform which is an international platform of BIRAC, where we have partners like Bill and Melinda Gates Foundation, Wellcome Trust, USAID, Rockefeller, and other people. We literally channelize global expertise, global innovative challenges, and try to bring a solution for India. Now, coming to your question, and I think Kamini elucidated very, very strongly. She is one of the leaders of AMR work in India, and what is the challenge and what the government is doing, what the researchers are doing, and what we are doing to enable solutions to these challenges. But coming back to the innovation thing and how we look at those challenges is, first, within a funding parlay, we look at an unmet need. To begin a story, you have to have an unmet need. Unmet need should be supported by strong science. It has to have a strong science, the unmet need supported by strong science, and then, which is 60 to 70% of the addressing that challenge, because without strong science, you can't address the challenge. And my esteemed panelists will definitely support that on. And 40% is how that strong science will move to the next level. Means, what is the validation or regulatory challenge to that science? Any science needs to be validated. So there are basically three parts to the science development where before it comes to implementation is discovery, then development of that science, and then it comes to either implementation or deployment and other things. So the first two parts, if we take to address is strong science, then how you navigate that strong science through a regulatory pathway or an IP pathway, or developmental pathway, taking that science, converting it to an entrepreneur model to deliver that science, to create a larger, and I'll come to the example. For us, let us go back to the basics of AMR. What is the first level of AMR is how to diagnose between bacteria, virus and fungus. That is the first level of the challenge which I think to tackle AMR we face. We get a fever, as Kamini said, that diarrhea hota hai, hum Norflox le lete hain. So, but whether it is a bacterial diarrhea or it comes from some other virus, we don't know. So there we need a diagnostics. And that diagnostics has to be supported with, that diagnostics means diagnostic, आज हमको fever आया, आज हमको diarrhea आया हुआ, आज हमको upper respiratory tract infection हुआ. So if we do a diagnostic and the result comes after 3 days, that is not a good solution. Because no doctor will, if you go to a doctor and he gives you a medicine and he said, aaj sirf paracetamol le lo, 3 din baad fever nahi utra, you come to me and I will give you an antibiotic, you will lose faith in the doctor. So it is a world that you will go to some different doctor. So every doctor, when you go, he will try to prescribe you an antibiotic, whether it's a bacteria. So what is the challenges? We don't have good diagnostic which will tell you in say 2 hours, 4 hours, 6 hours whether it is bacterial or viral. If it is bacterial, of course, whether the antibiotic is sensitive to that bacteria or not, to give you a prescription, that is the second challenge. So first level of tool to manage AMR is a diagnostic tool. So that within the system we have put out challenges, we are bringing out challenges to see how we can address that. And here the concept of 360-degree innovation comes into play, which most respected Dr. Selvamurthy also said, that team building to address those challenges. Team in the sense, you should have a basic researcher who understands, who is a microbiologist or a basic researcher, who understands what is the morphology, what is the physiology of a bacteria, what is the physiology of virus, what is the physiology of fungi, to address that. Then he can say how to diagnose that microbe. Then comes the clinical research, clinical expertise into it, that what I need a diagnostic, I need to validate that diagnostic, whether I am validating, that comes the next. And then once you do that, these two combinations, you need to do a bigger trial, you need to mass produce that tool. So you might need an entrepreneur to do that, you might need a company to do that, that is a different model. And then you have to get it validated. You need a clinical trial specialist who will do a device for you, a protocol, who will do a study for it. Then it comes the rollout and things like that. So the team composition has to be essential to roll out that problem to the next level. Once you do that, I'm cutting the story short. I think in short minute that bell will ring and Tavpritesh will go and stand up there. So the next thing comes is, when you do that research, the policy makers like Kamini, his team, and the big Ministry of Health will look at data. कि भाई आपने 10 patient पे try किया और 5 आया, that doesn't mean. You need to do a bigger study, bigger trial, bigger study to convince people like Kamini or her colleagues at the Ministry of Health to show them the data that this study, this diagnosis, this is a very good. The data has to be essential, which has to be statistically significant, which needs to be very well defined. So that needs a bigger trial to show. And then once the data comes out and data is convincing, it is good. If you publish that data, it is peer reviewed at a particular good journal, then you can go to the policy maker and say, see, this is the data. This shows that how I can manage this particular problem, and this shows that my diagnostic is better than the other available diagnostics, and it can reduce it. What a diagnostic has is it should be sensitive, it should be specific, it should be affordable. Because if it is not affordable, people can't use it. It is not sensitive, it doesn't hold good. It should be specific to that particular infection or a particular bacteria looking for, or a panel of bacteria looking for. So I think once you do that, you need to move forward to convince the policymaker with the publication, with the statistical analysis that this works, and then the implementation part can start. So saying so, within the funding agency, now I'll come back to the question which he had shared yesterday to me, that within funding agency we are doing, so this is one example I took of diagnostics. Kamini also spoke about that portfolio of drugs we should have, which is drying up for our country. There are drug discovery. Then we need surveillance tools. not only irrational use of antibiotics causing up AMR, there are a lot of other things like, poultries have been given bacterial drugs, and that also is helping in developing AMR through pollution, through sewage. So we need various surveillance tools to address the AMR through the One Health approach as well. So I think diagnostic at that level, the surveillance tools, the new drug discovery, development of vaccines, it has to be on a mission mode approach. And mission mode approach, nobody globally can teach us well than India knows. We did an absolutely excellent mission mode approach for COVID. I was privileged to lead the mission COVID Suraksha within the government, within this Department of Biotechnology, is that we developed 4 vaccines in a 12 to 14 months period, and these vaccines are comparable globally. Best all the platforms like mRNA, DNA, subunit, nasal, all vaccines were developed, and these are not vaccines that we bypassed any rule. We did good clinical trial, so Mission COVID Suraksha, if I say, was the mission mode approach to address the vaccine. It was not only, we only see the 4 vials of vaccine or the 4 different, but the background of it, we developed 50 clinical trial sites with ICMR. We developed 5 bioassay labs. We developed 4 animal challenge facilities. So I think that mission-made approach is one, and that was not only possible with one man, or we had clinicians working together, we had hospitals, institutes, academic people like Tavpritesh, and he seemed to look at data at various levels to tell us what is the serosurveillance prevalence, how to target it, the scientific team worked together. So that sort of mission mode approach we should know. Now coming to my final part of my thought is funding. Very well from this stage, as far as I have been working with the funding agency for almost 2 decades now, 2+ decades, funding is not a challenge anymore in our country. Especially I can talk about the funding which we look for good funding, and the government has created various mechanisms from literally funding from pre-proof of concept. At BIRAC, we have literally pre-proof of concept grant from students like you, like SPURSH program, where can you immerse and put out, to literally product commercialization grants. We have funding pot for everything. So funding is there, but compelling story like fairy tale needs to come to us. We have created almost 75 plus incubators around India where you can go and get yourself.
To commercialize and scale up the operations, we need private capital. And government also is thinking along those lines, and we appreciate that policy change. And Tavpritesh, you also mentioned in your last slide that there are short-term goals, and we focus on short-term goals, and we should wean away from that. And that's where I think the blended finance facility comes into play. In this, blended finance facility is a way of giving patient capital. So if you see venture capital, or if you see venture capital also, I would say is a bit of more patient than the stock markets. If you see the commercial capital and this thing, they go by quarter to quarter. This quarterly earnings report, BSE Sensex, Nifty 50, and this like. So they're all sort of, the whole private sector capital is short-term focused, and that's why they cannot handle public health well-being or public health goods like surveillance or social wellness. But what blended finance does is it tries to marry the philanthropic capital like government funding or foundation capital like BMGF, Rockefeller Foundation, etc. and with the commercial capital like banks, NBFCs, venture capital, equity like that. And what we try to do is we try to leverage the philanthropic capital to get social goals. And there have been many solutions, but I would like to focus on 3-4 solutions. So one of in the stories, there was a subplot about diagnostics, and now the doctors cannot wait for 3 days. And we completely agree with that. So we are trying to fund 2 entities. One is Rapidex. It was developed in C Camp. Another is Ramja Gen Sensors, that is there in incubated at IIT Delhi. And they give results in 7 hours. Not only the bacteria, they also talk about single drug resistance, multi-drug resistance. So they give the patterns, and that will change the prescription habit of doctors. Because as Sri Mukherjee said, the doctor cannot say like, I will give you tablets after 3 days, or this thing, you can only go symptomatic. So we need to change the private sector incentives, and now those companies, they have proven the technology, now they need to scale up. And that's where we come as a blended finance facility, and we try to give them different sorts of incentives. One might be co-funding, that is from BIRAC is giving grant, we'll try to match that with our this thing. Another is to give recoverable grants. So that so basically you should think of like a newborn baby, right? Startup is like a newborn baby, or a technology is like a newborn baby. And initially it is in the incubator. Like if you know about NICU, etc., you cannot just shut off the incubator or the NICU monitor in one day. You have to slowly wean away from that. Like even from breast milk also, you wean away the baby to take normal food. Like in that way, the startups needs to be held. And it's called the second valley of death. Like most startups, especially science-based startups, for software, etc., it's fine. Like they create an app, etc., and it's they can afford to fail. But science, it's the gestation period is long. You have to get that data, you have to prove, and then by that time, all the BIRAC grants, etc., they would be exhausted by getting the regulatory approval. And many of the startups, Indians, even though they've got a better technology, they don't even go for FDA and CE approval, the manufacturing facility. So at that time, if they want to take a loan, banks don't, their risk covers, and NBFCs, even if they give, they will charge very high interest rate, like 15, 20%, which would eat into the margins of the startup. So they won't be able to survive, even if they take that loan. So what blended finance does is, we either try to give collateral, so we give them a fixed deposit or something, park it with the bank, so that the bank can give a loan. In this way, they were not creating a dependency on grants. So what has happened is a grant dependency also occurs in, first they get BIRAC grant, then they get DBT grant, then they get DST grant, then they get BMGF grant. So then they become grant dependent and they only focus on getting next grant. So in this way, we can try to wean away from taking commercial capital and loans and then giving a guarantee to the bank. Either it can be a first loss guarantee or a partial risk guarantee. There are different changes, but I won't go into the details. Or we can give interest rate, which is bespoke, because most of the commercial, this thing is for established players, the commercial capital pool. So these startups, they need a specific sort of bespoke commercial tools, and I think blended finance can play a role. And I'm happy to say we have been able to achieve and prove different models in that. Thank you.
Thank you for introducing the new models of blended finance, especially tying data to availability of data to financing. Although I think there's a lot of publicly funded research happens where data should be publicly available, so should not be tied to that financing model. But that's a question that we can discuss offline. We have 5 minutes. Sachin is saying that we should wrap up, but I do want to give 5 minutes to the audience to ask questions to this esteemed panel. You may not have the chance to interact with such an esteemed panel of this platform. So please, short questions, and I would request 1 minute answers from the panelists. So questions, please. Yes.
Hello. Thank you, ma'am, for the. I have a question from you, ma'am. I wanted to ask you that what is the work done by ICMR to get the data from last miles of the country? Like the rural setup doesn't have that much of good health services. So how do we collect the data from the last miles so that the data is more relevant?
Yeah, thank you. Thanks for that question. And we are aware that ICMR's network mainly collects data from the tertiary care hospitals. So it is not representative of the general country situation. So we are very well aware of that, and we are now working with the NHSRC, the National Health Mission, and through them we will be working with the district hospitals, because many states have now started procuring antimicrobial susceptibility systems, the automated ones, and also now hiring microbiologists. But please understand that many of the district hospitals and the setup, which is falls under secondary and the lower levels of hospitals, do not have the laboratories, well-equipped laboratories, and the manpower to help with this. So that has been one of the key challenges. Other than that, we are also exploring the possibility of extrapolating genomic surveillance data for getting community level antibiograms. So this is something which is a high priority for ICMR, and shortly I would say you should be able to see some data coming from the rural settings as well as the secondary level healthcare system. Thank you.
Sachin has a question.
First of all, thank you for a wonderful panel. And I have attended Dr. Mukherjee's master class. It's always really nice. This was not the right platform. But I just wanted to make a comment on Dr. Selvamoorthy's presentation. So it was, I think, twice I was told to read this book, Ministry for the Future. And this book is set in Lucknow. And the book says that in certain year in the future, there are at least 15-20 million people dying just in a single day. And that is because of the wet bulb phenomena. So sir, it was nice to see that you make a remark on heat waves. But do you think we are, as a country, are prepared that when 20 million people can die in a day? And do you think it's going to happen?
See, the first is creating awareness among the public, because heat-related disorders, in military we have already done it. Like, for example, in summer months, your work routines, the training, development, activities start very early in the morning and finish by about 11 o'clock. So we have scheduled in the army training programs, these taking into account the heat stress which is rising. Similar awareness, you should give it to farmers. They should start the work very early in the morning and then finish the work by about 10 o'clock, 11 o'clock. So one is creating awareness and behavioral adaptation. This is one aspect. Then the second is we must also create the hydration level to be maintained. For example, the ergogenic drinks, which is available today, how do we make use of it, which takes care of fluids and electrolytes, which is very important for heat stroke and heat-related disorders. So more such drinks should be made available, which gives energy for the work as well as for taking care of fluid electrolyte balance. So such kind of awareness need to be created. And also in the hospitals, how do we address this problem of heat-related disorders when it comes? And preventing the death, because that is important. Because these are very important that, you know, the dehydration at the intracellular level should be protected. So that is what physiology shows. So how do we allow this within 2% dehydration level? So we need to make such behavioral changes, educate the people, and then we should be able to take care. And India has got that kind of resilience always to adapt. And we adapt not only physiologically, but also behaviorally. So that I think we will mitigate this problem by these two interventions.
One last question. Anyone? So if there are no questions,
I'll add something.
yeah, sure.
So by ending, I'll tell you a story, and you should all know this story. Again, a COVID story. You know, the mission mode concept which I brought in, that is what, you know, how many billion doses of vaccine Pfizer produced? Anybody can tell in this room? 2.65 billion doses. Moderna produced how much? 1.3 or 1.4 billion doses of vaccine. The total kitna aata? 4 billion. When within the leadership of the government they started कि India में हम कैसे vaccinate करेंगे, and how Mission COVID Suraksha came in, is that we required 2.5 billion doses vaccine for our country. 2 doses देना हो, 90% coverage. So nobody would have given us this many vaccines. Nobody, और देता भी कोई, तो what was the cost of per dose of vaccine was huge.